So welcome to our 7th session of Childhood Trauma Consequences and Essential Responses. Today we're going to be discussing working with trauma survivors in a neurodevelopmentally aware, trauma responsive way. The image on the screen is used with the kind permission of a woman called Liz, who I met virtually on Twitter, like so many of the people in my world these days. Liz was a child of the care system, and while you cannot really read the words that make up the image of the woman on screen, that's entitled Redacted. I'll read some of them for you. Unstable is one, poor attachment is another, high-risk patient is another, psychologically refuses to, start again. Welcome to week 7 of Childhood Trauma Consequences and Essential Responses. Today we're going to discuss working with trauma survivors in a neurodevelopmentally aware, trauma responsive way. The image on screen, named Redacted, is by a woman called Liz, who I met on Twitter, and I asked Liz to use the image with her permission, and she was very happy for me to do so. You probably can't read some of the words that make up the woman's face, but vulnerable is one, distorted perception is another. What else? Manipulative, overreaction, emotional, vulnerable. Tears did not seem genuine. So these are words that appeared in Liz's care file. She was a child of the care system, and the black things etched out that actually make the shape of the face are words redacted from her file. And the words that I just read out there to you, there's also stuff about overreactions and delusions of grandeur and this type of thing. They're quite abusive terms, actually, to describe someone who was a traumatized child, because you do not end up in the care system without an extensive history of trauma. Now, there are lots of people with extensive histories of trauma, of course, who don't end up in the care system as well. But people who are from poor backgrounds are much more likely to end up instituting or being the subject of care proceedings rather than people with higher levels of income. That's just the way it is. And it's unfortunate because being in care can be a trauma in and of itself, especially if people are subject to multiple care placements, because their behaviors might be challenging. They might run away, they might be aggressive, they might be physically abusive at times, and people can't handle them. And so the placements break down. And so the cycle of rejection and further trauma continues. There's a nice quote as well at the bottom from Judith Herman's brilliant book, Trauma and Recovery. It's from Lenore, who is a trauma recovery group participant in an incest group. And she said that the biggest things for me are the benefits of not keeping a secret and being able to talk about things that I thought that if I ever talked about them, I would melt and disappear into the ground, or people would go scurrying from the room like rats. And I found that didn't happen, both for me and the other people. And that's so important. Very often when people reveal their deepest, darkest secrets, particularly about things like child sex abuse, people in their lives do go scurrying from the room like rats, including good friends of theirs. I've heard of people dropping friends like a hot potato, or being rejected by family members. And this furthers the trauma. So not only are they wounded terribly by the person who actually perpetrated the crimes against them, but then they're treated as if they are somehow at fault, or they're disbelieved, or at any rate, the denial sets in and they're cut out of people's lives, which is very harmful. So not scurrying from the room like rats if you're told something is an essential step, actually, in becoming trauma-informed and responsive. It's the least that we can do. So this is my daughter, Aurora, a few years ago when she lost a tooth in 2018. So yeah, several years ago now. She only lost 2 more teeth in recent weeks, and Peace Blossom, her fairy, is being bankrupted with all the teeth falling out. But at any rate, on this occasion, she gave me her tooth on the way home from school. It was a dark winter's evening. I put it in my back pocket and somehow lost it. It fell out on the way home. She was devastated, bawled her eyes out. And I was getting dysregulated from her dysregulation and her upset at the fact that the fairy would not come. But then I had a brainwave and thought, you know what, we already have a relationship with this fairy, Peace Blossom III, who wrote Aurora letters from the first tooth that fell out and is still writing them years later now that she's nearly 10, and has brought her books as well as, you know, coins and €5. And I think she got a couple of €10 for her 2 front teeth. So this fairy is far more generous than any I came across in my youth. But the point is about the relationship. Because we had built this relationship with her tooth fairy, Peace Blossom the third, I suggested that we write to her, explain that I lost the tooth, and maybe she would come anyway. And sure enough, she did. And the point about this story is that it's in the and. That is a phrase used by Ciara McCarthy, a senior clinical psychologist, at an event on trauma and the prison system that I played a part in organizing a few years ago, again in 2018. But it's in the and means there's no such thing as a baby on their own or a small child on their own. It's the baby or small child and their caregiver. That's the dance of attunement that we've discussed before. They exist in connection with others. They exist in connection with those entrusted with their care. And that's usually their mother and father, or sometimes it's just their mother. Sometimes I guess it's just their father, or it might be grandparents, or it could be foster carers or other kinship carers or adoptive parents. But the point is, babies and small children exist only in connection with others. And I did as best I could in that stressful circumstances by being solution focused. What mattered was that she got her money from the tooth fairy, really, and that we avoided this chaos. So our role as caregivers of small children is to try and regulate their emotions. And to do that, we need to do our best to stay regulated ourselves, which is not always easy. But the relationship stays important throughout a person's life. And where people have experienced a lot of trauma, the relationship in a therapeutic setting is vitally important. People who never felt safe at home are going to find it very difficult to feel safe anywhere, including in services designed to help them. So there was a very important article from 2005 where Elliott and colleagues identified 10 principles that should be incorporated in any service working with female trauma survivors. The first principle is that trauma-informed services recognize the impact of violence and victimization on development and coping strategies. Principle 2, that trauma-informed services identify recovery from trauma as a primary goal. Principle 3, trauma-informed services employ an empowerment model. Principle 4, trauma-informed services strive to maximize a woman's choice and control over her recovery. Principle 5, trauma-informed services are based in a relational collaboration. So this means safe relationships are consistent, predictable, non-violent, non-shaming, and non-blaming. Very challenging at times when people might be being abusive themselves or self-harming or not turning up for their appointments. Sometimes service providers, though well-meaning, find it very challenging to not be shaming and non-blaming and not engage in violent communication. Principle 6 is that trauma-informed services create an atmosphere that is respectful of survivors' need for safety, respect, and acceptance. Principle 7, trauma-informed services emphasize women's strengths, highlighting adaptations over symptoms and resilience over pathology. Principle 8, the goal of trauma-informed services is to minimize the possibilities of re-traumatization. Principle 9, trauma-informed services strive to be culturally competent and to understand each woman in the context of her life experiences and cultural background. Principle 10, trauma-informed agencies solicit consumer input and involve consumers in designing and evaluating services. And there's the link to that article there, or the citation rather, to the Elliott and colleagues article from 2005. So there are 10 principles there that are highly influential and remain relevant to this day. In terms of culture, again, that's very important if people are working with women or men, for that matter, or children from particular minority ethnic groups. So if in Ireland, services are aimed at refugees who may have fled scenarios where they were subjected to torture, then being respectful of their unique cultural heritage is very important. And also being sensitive to the way white supremacy and racism play out in the world. If we're white people, we need to be aware of our privilege, and we need to be aware that other people don't necessarily see or experience the world as we do, because they might lack our privilege that's conferred because of our white skin and the way that the world has been set up, and the impact of colonization. The other thing about cultural competency in the context of working with groups like travelers is that all service providers and frontline staff need to be aware of the culture. They need to be respectful of it and check their unconscious biases, and really, really strive to make people feel safe and listen to them and not presume anything. So I think that all frontline services working with particular groups do need cultural competency training and need training around race and white privilege in order to minimize the harm of re-traumatization. These are SAMHSA's 4 R's coming from a document about trauma and guidance for a trauma-informed approach from 2014. The paper was aimed at staff in services and systems delivering trauma-informed care, and called on these people and systems to realize the widespread impact of trauma and understand, okay, I'm going to say that again. SAMHSA's paper was aimed at staff in service. SAMHSA's paper was aimed at staff in services and systems delivering trauma-informed care, and called on them to realize the widespread impact of trauma and understand potential paths for recovery, to recognize the signs and symptoms of trauma in clients, families, staff, and others involved with the system, to respond by fully integrating knowledge about trauma into policies, procedures, and practices, and to resist re-traumatization, which is exposing survivors to avoidable trauma triggers. Now, it must be said that we cannot eliminate triggers for trauma survivors. We can't, because we cannot possibly know all of the things that might be traumatic or triggering to trauma survivors. It can be a smell of a perfume or an aftershave, or it could be, curtains, or it could be the time of year. It could be something really very quite small and something that they have no real conscious memory of indeed. But the point is, there are some certain things that we know are going to be potentially traumatic to people, including having beds in office spaces, perhaps, because for those who have been sexually abused as children, that will often have taken place in a bed. So having beds in people's offices, for example, in homeless accommodation, where staff might have a nap or something like that in the middle of the night, if they're doing night shifts, having a visible bed in an office might be activating to people, because it'll remind them of what happened to them. So just being aware of these type of things is very important. Similarly, religious iconography, so statues of Holy Mary or Jesus, might be quite activating to people who were abused by members of the clergy. So our public buildings, including hospitals, really probably should not have them everywhere, because they're going to be distressing to some people who walk in to use the services. So there are certain things that we can know in advance are not going to be helpful, and we shouldn't then subject people to them, arguably. Actively resisting re-traumatization means that we give thought to our buildings and give thought to the messages that we have on the walls and that type of thing. And really, one way of resisting re-traumatization is to assume that actually everyone using our services is a trauma survivor, whether they are or not. Because when all people are treated as though they're trauma survivors, if they're not, they'll get the benefit of being treated respectfully and gently and having their safety prioritized and their choice and voice and all of these things that are core principles. But if they're not, or rather, if they are trauma survivors, in particular, they will really benefit from having systems that are not trauma blind and that actually know that so many mental and physical symptoms are due to trauma histories, and that we don't routinely blame and shame people if they do miss appointments. We realize that for those who most need our help, it's most difficult for them to get in the door. That's the simple fact. People who have better functioning and who need services less are the ones who find them easy to access, especially things like mental health services. But if we treat everyone as though they're potentially a trauma survivor, then the risk of re-traumatizing those who actually are survivors are minimized, and everyone else gets the benefit of this safer, more culturally responsive, gender responsive treatment. SAMHSA recommended that communities tackle trauma by viewing it as an important component of effective behavioral health service delivery, and stated further that it has become evident that addressing trauma requires a multi-pronged, multi-agency public health approach inclusive of public education and awareness, prevention and early identification, and effective trauma-specific assessment and treatment. A trauma-informed organization or community is knowledgeable about trauma and its various manifestations. So there's a number of things there. It needs to be multi-pronged, multi-agency, and a public health approach. So it looks at the population level and tries to prevent it and also respond more effectively when trauma has happened. It includes public education and awareness. Where do we in Ireland have public health advice and public education and awareness from our state, from the likes of Tony Holohan, who is our Chief Medical Officer? He does a good enough job on COVID and the public health campaign around that. But what about trauma and adversity? What about a public education campaign about the importance of preventing and early identification? What about trauma-specific assessment and treatment? We're light years away from having this type of a system in Ireland, and we need it badly. So here are just a couple of graphics, again, to remind us of the window of tolerance and polyvagal theory by Stephen Porges. And the window of tolerance came from Dan Siegel. And you'll remember that people who grow up in very unsafe households, where they're emotionally dysregulated most of the time and they never return to baseline, they have a fixed allostatic load, they will have a really, really tiny window of tolerance. And if they are met by trauma-informed staff and services, then part of the goal should be to help them safely to expand their window of tolerance over time so that they don't respond explosively to every little provocation, or that they don't dissociate when someone looks at them with a bit of a grumpy face, so that they're not constantly in survival mode, that they can learn to tolerate a bit of stress without their autonomic nervous system really kicking in. Trauma-informed or responsive, according to Jim Sporleder, the former principal of Lincoln High Alternative High School, which was in Paper Tigers documentary, he said the trauma-informed or responsive is best understood as a way of being or who we are. So it's not a box ticking exercise. It is a way of being. It's who we are as people. It gets into our blood, into our hearts, into our minds, into our language, into our ethos, into the way we interact with one another as staff, into the way we interact with people who are availing of our services. It's about being loving and compassionate and patient. And where we get it wrong, as we inevitably will, because we're human and we get emotionally dysregulated and we get subject to stress, when we're a little bit short-tempered, or where we don't model the model, as Karen Traceman says, we attempt to repair it. We attempt to repair the harm by saying we're sorry, meaning it, and moving on. And too often we expect apologies and empathy and concern for the victim from trauma survivors, but we don't show them what that feels like to be on the receiving end of the empathy and you know, the patience and the compassion. So we do need to model the model if we're engaging with trauma survivors, or if we're just engaging with people in general, including our own friends and family members, our colleagues. We need to make relational repair where there is a relational rupture. SAMHSA has identified 6 basic guiding principles of trauma-informed care, and you're likely to come across these in probably any training or any talk about trauma-informed care that you might attend. So the 6 guiding principles of trauma-informed care are safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. I would just say, in relation to safety, I'm not sure that it's always emphasized enough that this needs to include a felt sense of safety in the presence of others, to go back to polyvagal theory and neuroception. Neuroception is the unconscious detection of threat in our environment. So people, in order to feel safe in a service providing any kind of trauma-informed care, they need to have a felt sense of safety in that place. People will often talk about emotional and psychological safety, but we won't really have these if our bodies don't feel safe in the presence of other people, is my point. So the physiological aspect of safety is often missed because the concentration is on the mind and the emotions, but really our mind and emotions are hugely linked to our physiological state. SAMHSA's principles shouldn't be, again, viewed as a simple checklist, because becoming trauma-informed and responsive, it's a very, very long, slow journey. It doesn't happen overnight. Doing a week-long or 2-week-long or a year-long training, if such a thing existed, wouldn't necessarily make everyone trauma-informed and responsive. You really need to put it into practice. You need to reflect on your own behavior. And again, Haas and Clemens say it's best understood as a way of being. So the information is absolutely crucial. And one of the reasons that I give you guys so much information is that it will help you reflect on yourself and reflect on colleagues and reflect on friends and family members in a different way. All the information is helpful, but unless you start to moderate your own behavior and tune into your own body more and notice when you're becoming emotionally reactive and dysregulated, and try and, you know, do some coherent breathing, or practice some trauma releasing exercises, or join a choir, or do some polyvagal informed activity, nothing will really change if you don't consciously try and watch your language, you know, and practice compassion and practice gratitude as well. You know, be grateful for the good things in your life and the supportive people that you have. And also mind your boundaries. Sometimes boundaries are put up as a blockage to actually caring for people and being loving and listening to them and prioritizing their well-being. But we do need boundaries as well for our own safety and well-being, and to ensure that we can be giving to others and compassionate and patient. We can't do that if our cup is empty. So we'll talk a little bit about care, self-care towards the end of this session. Jim Sporleder as well states that when a trauma-informed or responsive ethos becomes our identity and our culture, it then drives who we are as a person and defines our vision as an organization. Dr. Karen Traceman, in her publication there for the Winston Churchill Memorial Trust on becoming a more culturally adversity and trauma-informed, infused and responsive organization from 2019, uses the trauma river metaphor. And she says that there are 4 stages to the journey along the trauma river regarding organizational or systemic change. And it starts with okay. So according to Karen Traceman, there are 4 stages to the trauma river, starting with trauma sensitive, then becoming trauma aware, trauma informed, and trauma responsive. Now, many experts, including Haas and Clements, place trauma responsive before trauma informed, but like Karen Traceman, I prefer having trauma responsive at the end of the trauma river as the descriptor for the final stage in the process, because really it better actually conveys what we mean. It's not just having the information and doing nothing really with it. It means responding differently to people who present with trauma histories. It's about being trauma reducing as an organization or a system rather than being trauma inducing. Again, that's a phrase from Dr. Karen Traceman. And it means that staff in the service or the system have really embedded this kinder, more compassionate, neurodevelopmentally aware, deeply relational way of being into their own behavior and interactions. And they know the importance of modeling the model. For me as well, trauma responsive suggests that services, systems, and institutions buffer their staff as well against the strains of working with survivors and provide them with appropriate supervision of a therapeutic kind as opposed to just case management supervision, and also prioritize staff self-care and self-compassion. Importantly, absolutely anybody can become trauma-informed. You do not need to be an expert. You do not need to be a psychiatrist or a psychologist or a social worker or, you know, have a PhD in anything. All human beings, I believe, should be trauma-informed. And sometimes I get annoyed when people, professionals, talk about this subject matter all the time, but aren't really focused on getting the information into the hands of people who need it most. That is ordinary men and women and people in their worlds, so that we can better support parents to care for their children, and that we can better support communities to become resilient and strong and healthy places. So this is not information that needs to be kept for professionals. All professionals need it, but anyone can become trauma-informed. So when an individual, agency, or setting is trauma-informed, they realize how widespread trauma is, recognize the signs and symptoms, respond by including a trauma perspective in policies and practices, and resist unintentionally re-traumatizing clients or staff. Unlike delivering trauma treatment, which usually requires a trained professional, anyone can become trauma-informed. And that is from Blanche's Toward a Trauma-Informed, Resilient and Culturally Responsive Alaska on page 3 with the link there. This is a nice little graphic by Pertl, and it's about trauma preventive, trauma-informed and trauma-specific policies, and it's contained in the Mobilizing Action for Resilient Communities report, which has a specific focus on policy and advocacy matters. And Pertl identifies trauma preventive measures as including the creation of conditions for safe, stable, nurturing relationships and environments that reduce exposure to trauma, and gives examples such as family-friendly work policies like paid leave and livable wages, laws that reduce easy access to dangerous weapons. So this report, the MARC report, is an American report. And that's very important to bear in mind. Again, we were talking about the biopsychosocial or the bioecological context of parenting and child development in previous sessions on the Bronfenbrenner model. Well, in America, there is no paid parental leave, really, or paid maternity leave is very, very brief. And it's only people with pretty good jobs that get access to it in the first place. So moms end up going back to work too soon for themselves, but also for their baby's development. And so that isn't really a social policy that is conducive for healthy human development. Also, the proliferation of guns clearly is not conducive to safety and well-being. And I interviewed a woman called Robin Cogan, who's a nurse. She has a blog about the resilient school nurse, which is really interesting. And she comes from a family where there was gun violence. And she's a major campaigner on gun reform laws, as well as healthy school practices around COVID and that type of thing. But every country, every nationality has different contexts that need to be borne in mind. And these examples from the American context obviously are very pertinent there. But there was a time in Ireland where there was no paid maternity leave either, or paid paternity leave. And these things are important for creating healthy humanity. Trauma-informed then, Pertl says you raise awareness about trauma and you promote trauma-informed practice. And an example there is mandatory trauma training for staff. I couldn't agree more. I firmly believe that all staff in all sectors should have this, because even if you're working in a factory on a conveyor belt, there's likely to be trauma around you too. And people in every context deserve to be better understood, to feel safer around other people, and to be met with compassion when they're struggling. Trauma-specific interventions then include increasing access to interventions and services that mitigate the impact of trauma and promote healing. And an example there again from America is Medicaid reimbursement for trauma-focused treatment. This would also be relevant in Ireland because our system is currently quite trauma blind. If you've mental health problems, you're most likely going to be treated by medication. This is called the medicalization of misery. There may or may not be better ways of treating your symptoms, including psychotherapy or sensory motor psychotherapy or somatic experiencing or deep brain reorienting. But because so much money is pumped into research by pharmaceutical companies, there isn't the evidence base to support some of the more novel somatosensory approaches to trauma treatment. And really, we just need a wider menu for people, because one size absolutely does not fit all in this regard. So there is a tyranny of silence right now. And we've got to ask ourselves, would it be wise to ask every child, or at least ask every adult, about their exposure to trauma and adversity? And Dr. Nadine Burke-Harris, the Surgeon General of California, in her book from 2018, says that the ACEs framework is powerful because it opens a dialogue about topics that feel largely taboo in our society. And this is particularly the case for things like child sex abuse and incest. They happen in families the world over. They do not really discriminate in terms of education level, religion, class, or creed, or education level. And so she says that routinely screening for ACEs means that we have these conversations that are uncomfortable, but at least offer people an opportunity to bring their silent struggles into the light of day, so that they don't have to go to their deathbeds having never told anyone about what happened to them. Whitfield, writing in 1998 when the ACE study came out, said that between 50 and 70% of people who require psychiatric inpatient treatment or outpatient treatment are trauma survivors. John Reed and colleagues found that survivors in mental health settings were frustrated that staff avoided asking them about childhood trauma. One interviewee stated, "I just wish they would have said, 'What happened to you? What happened?' But they didn't." And that article about why, when, and how to ask about childhood abuse is really, really interesting if you can locate it. Reid and colleagues say that every patient should be asked about trauma as a matter of course at the initial assessment, if at all possible, as part of a general psychosocial history, unless the person is in crisis. So clearly, if they are very disconnected from reality, or maybe self-harming or being violent to others, that would not be the time to ask them about their trauma and adversity. But in general, if people are not in crisis, they should be asked at the first assessment, because otherwise the tendency will be to only ask people with specific types of symptoms, for example, PTSD type symptoms with flooding and nightmares, who've survived warfare or maybe rape. And there's a very low spontaneous disclosure rate documented. So Reid and his colleagues say that waiting for clients to disclose abuse simply does not work. Mental health professionals must actively elicit each person's narrative. So here are a bunch of links to my podcasts with people who have mental health histories. And when I say histories, they're experts in this area. So Warren Larkin, Dr. Elizabeth Gregory, Judge Ginger Lerner Wren, who set up the first mental health court in Florida, Dr. Pat Bracken, Dr. Lucy Johnston, who is a key player in the power threat meaning framework, and Dr. Bruce Perry, again, who's a child psychiatrist, neuroscientist, and author, including of a book recently with Oprah Winfrey called What Happened to You. So we need to shift profoundly away from what's wrong with you to what happened to you and focus on that, but then also look at the strengths in a person's life and make them aware that their behaviors or their symptoms, with the symptoms as a kind of very much a biomedical type way of looking at people's adaptive behaviors, that then over time, albeit, can become maladaptive because they're no longer really serving them. But they began as attempts at a solution oftentimes. Anyone working with trauma survivors must consciously resist traumatic reenactment or repetition compulsion. They're the same thing, they're just different ways of referring to the same thing, traumatic reenactment and repetition compulsion. They are basically a psychological phenomenon where people unwittingly repeat past patterns and experiences over and over. And they're harmful experiences, they're not good ones. There are things that cause them harm and suffering, oftentimes when they were children, and they keep trying to elicit the same responses again. So if they had rejecting, abandoning parents, then they will try and get similar responses from their loved ones in the future in their intimate relationships, because that feels familiar. They might goad people or push people to reject them when the partner maybe doesn't really want to reject them, but because of their relational dynamics, it can just be a never-ending cycle of this dysfunctional way of interacting. So our attachment relationships in infancy carry over into all of our future relationships, especially if we're not aware really of what we experienced. And they particularly influence our dynamics with our own partners as we become older. Our pre-verbal implicit procedural memory and our experience of emotional neglect, our attachment style, whatever trauma history we may have, might also present difficulties in our interactions with teachers, psychologists, and social workers. And this process is also known as transference. In the community mental health context, Keeley and Unung state that people who were neglected or abused by a caregiver may face tremendous challenges in their attempts to engage in a therapeutic relationship later on, potentially anticipating similarly rejecting or hostile responses from a new provider of care. The unconscious detection of threat in the environment is, however, an automatic response to living in a world where relationships have been experienced as harsh and dangerous. So we shouldn't take it personally at times if we work with trauma survivors and they seem to be wanting to draw negativity from us. We need, though, to be very reflective about what is going on and be mindful of the fact that, you know, this feels, being rejected might feel very familiar to them. Being kicked out of a service might feel very familiar to them. That might be actually what they unconsciously want. But our job to try and help them and to facilitate their healing and growth is to try and stick with them. And to stick with them when the going gets tough, when we're at the end of our wick because of the carry on from them maybe, or what they're saying, the hurtful words that they might be saying. But it's not about us. It's the past replaying in the current moment. And if we're not very conscious of what's going on, we will then maybe take on the role of the abuser or the cold rejecting parent ourselves. So this is where the awareness is vital, but also the self-reflection and the focus on our own regulation is crucial. Hostile attribution bias again, and neuroception. So Dr. Karen Traceman describes hostile attribution bias as face and mind reading difficulties. And according to Stephen Porges, traumatized people have an unconscious neuroception that is highly attuned to danger signals. So they will be prone to reading even neutral cues as threatening. And so if they see a fairly blank face, that to them will be read as a danger cue. Whereas to someone without a trauma history, they won't fixate on the face whatsoever. Trauma survivors are simply more emotionally reactive as well to negative facial expressions. So if I look angry, a trauma survivor is going to be more activated by my anger and my angry face than someone, again, who's been lucky enough to have a safer, more relationally healthy time in life. According to Bruce Perry and colleagues, prisoners, approximately 90% of whom have trauma histories, are really likely to respond to personal space violations with aggressive and violent behaviors. Again, this is because they've learned that you need to respond quickly to aggression and violence. As babies and small children, they weren't able to do so, but from growing up in violent homes and violent communities, responding quickly and having this predisposition to view the world as a hostile place and all the people in it as potentially violent, that can be life-saving if you inhabit a world where those very capacities have kept you alive before. Well, it's not actually hard again to see how violence can be an attempt at a solution as well, namely to keep myself alive. Okay, I'm going to stop sharing now and share my screen again.
Thank you so much. I'm so happy to be here, and I took like a million notes, even though this work is very familiar to me. I still took a million notes on this class, so I feel like being a student here. So I'm Sissy White. I'm a writer. I'm a trauma survivor. I was diagnosed with PTSD from developmental trauma in my early 20s, which was 30 plus years ago. And the reason that I mention that is I was diagnosed fairly soon after the PTSD had been introduced to in the DSM. And at that time, it really, I, like many people, thought this, how could I have PTSD? I thought only vets got that. I didn't understand when I got that diagnosis that I could have that, or that was even possible. Despite having known I had a rough childhood, it never occurred to me that I had traumatic stress. And that's fairly common as well. So I think a lot of us, even who are trauma survivors, don't necessarily know we're trauma survivors, don't frame it that way, because maybe everyone in our family is a trauma survivor. So it's very normal to us. So I guess the main thing I was thinking when Jane was talking was, and I don't know if you go by Professor or Jane, if I can call you.
No, just Jane, please.
Is, you know, trauma informed responsive is really helpful concepts for all of us. And I think as a culture, part of what the beauty of the ACEs study has done is helped make it more conversational and less shaming. And the reason it's done that is kind of that whole what happened to you versus what's wrong with you thing, is that ACEs frame the issue as the problem is these negative experiences that happened, or the lack of positive experiences that happened. Prior to the way ACEs study framed trauma, it was really like, what is your problem? What is the problem you're having? What were the failures? What went wrong? How did your parents fail? How did others fail? It was really a fix model, like something's broken in you and we got to fix it. And in a lot of systems, even if you were willing to share an abuse history or a trauma history or interpersonal violence, you could tell that the provider was uber uncomfortable. It was kind of like, oh, like, please do not answer that question. Please do not bring that up. Or they'd ask something about, like, in my example, my father was homeless and he had been in Vietnam. He was a vet. When he came home, he never was housed or stable after that. And we didn't really have a relationship. So I'd do a family history and they'd ask about your father. And I'd be like, I don't know my father. And they'd be like, what do you mean? And I would say he's homeless or he's an alcoholic, and you could tell for some people that was just very conversational. Like, we all have parents and we all have histories, we all have stories, and some of them are good and some of them are bad. And for some people it freaked them out, and you would end up being like protective, but I deal with that in therapy, I don't want to talk about it here. Like, you could feel the palpable discomfort of like, please don't go there, please don't go there, like, I'm out of my depth. So I think part of what the ACEs study has done is given us all some ways to talk and think about adversity, and kind of with the focus on what things maybe have happened to us or have we experienced, or what things with safety and attachment have we not experienced. And I think for me, the power in that is that we are all impacted by the presence or absence of trauma, and by the presence or absence of safety, by the presence of absence of resources. And so that looks very different for all of us. You know, if I have 1 ACE versus 10 ACEs, you know, we're all impacted. I feel like it's very similar to privilege. It's like we all have some areas where we're marginalized. Well, not all of us. Most of us have areas where we're in a marginalized community, but maybe some of us have several areas where we're marginalized. Maybe some of us have several areas where we have a lot of resource and privilege. Like, but most of us have an experience of having some areas where we are and some where we aren't. Same with pain, sorrow, and trauma. You know, none of us have gotten through life without some pain, betrayal, hardship. The degrees, how much that matters, how much that shapes us, if we're in survival mode or not, like, that's what varies. So I guess the main thing, you know, Louise Godbold is a trauma survivor, and she also does a lot of work with parenting and a lot of training around trauma. And she has just completely disregarded trauma informed and now says survivor informed. And I really like that, because really what she's saying, like I used to say, it's not trauma informed if it's not informed by trauma survivors. But I like survivor informed even more, because what she's saying is, in every interaction, it's centering the needs and safety of the survivor before you. That could be yourself, if you're a survivor, and making sure you're regulated and how's your stuff showing up. Also with the survivor you're working with. And you may be in a direct role where you're helping somebody identify and even learn, like, what is safety, what is attachment, what is that, or that may be a secondary role. Like, you're in a system where it's an education system, and the primary goal isn't necessarily to treat trauma, but you are definitely educating trauma survivors as well as people who have not experienced trauma. So, you know, the level of responsiveness to trauma, I think, also varies depending on what setting you're in. But I think a comfort with language and concepts and being able to discuss it is safety setting, but also being really specific to the survivor in front of you, because I've seen the pendulum shift in this movement, you say survivor movement, from talking about trauma all the time in detail and that you have to feel it to heal it, which used to be the way, like, you know, if one talk therapy didn't work, you know, that wasn't working, then you'd go like 3 times instead of saying maybe it's the approach that's not working and we need something like more body-based. It used to be more is better and talk about it all the time. Now the pendulum's kind of swung where it's like, no, you don't have to get activated. We don't need you. You don't need to speak about trauma. You don't need to tell your story. And it's sort of like, sometimes maybe you want to and do want to tell your story, and other times you don't. So I think there isn't like a rule for how to be with survivors. It's more what place, space, and time, you know, is the survivor in? What's your role? What's your comfort? What's your limit in how you're interacting? And I think being survivor informed in that way in each interaction is most important, because it isn't the same survivor on a different day is going to need something different. And so I think asking survivor what they need, centering that, which seems really obvious, but it incredibly doesn't happen a lot. And survivors are not often a part of developing systems or co-creating systems. In a lot of other types of advocacy, survivors are central. In the cancer community, for example, you know, you'll have a lot of patients on panels and survivors of cancer who are actively engaged in kind of helping recreate the medical system, at least in a cancer setting. It's less often in the survivor community. And I think in the past, it used to be a lot of providers felt like I work with survivors, so I can speak for survivors. I know survivors. And I think that's a flawed assumption, because working in a certain setting with survivors is a very limited window into knowing a fraction of a survivor's life and history. Like how we show up in a system setting, for many of us, we don't identify ourselves as clients, consumers, you know, it's way more complex than that. And that's like a tiny, teeny, tiny piece. Like a clinical hour is a tiny part of our lives. How we manage being a trauma survivor with parenting, with work, with being in relationships, with managing the bus system, with travel, with cognitive impairments, with poverty, with whatever the other issues are. Some of those other issues may be the dominant thing. Or it's the intersection of the issues that are the thing. And there's no way to know that ahead of time without being curious and asking the survivor that you're working with. I mean, I think that is really the key, and also what's really hard, because I mean, I want a checklist, you know, like I want to know something that's going to work every time with everyone, that's always safe. And what's triggering for me, even, you know, has changed over time and years. What feels safe has changed and evolved over time and years. So it's not even like one setting or one environment. It could change depending where somebody is in their healing and their process, and depending on what level of trauma, type of trauma, what recent adult trauma may have reactivated some old thing. So I think that's important to understand too, and in some ways, I think why people like Jim Sporlater say it's a way of life, because it does change the way a lot of us operate. If we have to be way more relational, and many of us haven't been raised that way, like a job is a job we do, and we want to do our job well, and we're not necessarily like doing it a little bit differently for everybody. We're not necessarily putting the relationship first. We're like very task oriented. So it does require a shift. And especially if we're in a system that has been very rigid, it is hard to be in a rigid system and then also allow a lot of survivor control, agency, choice. Sometimes that can feel like that's at odds. So, I mean, that's my kind of general thoughts, but I'm happy to expand or go into anything or to give examples of, you know, ways that of being in systems that can be super helpful and ways that have been super unhelpful. I will say, I do like Dr. Vincent Folletti. He phrases, when he talks about trauma, he asks people, how do you think your ACEs have impacted you? So it's a very open-ended, but also I feel like it's a good example because he just assumes that it does and lets people say, like, okay, I may have some ACEs that I don't really feel like they affect me. I feel like, you know, like it's not every ACE doesn't affect us necessarily equally. There may be some things that we're presenting at 25 at a doctor's appointment, and we're very aware that one particular ACE is impacting how I'm showing up in my relationship. But in my 30s, maybe it's a different issue that's showing up in the way I'm parenting. And in my 40s, you know, if I'm hitting menopause, something else may be coming up that's bringing me back. So it's not static. It's not the same. It's not like even as a survivor has one relationship with childhood. If you have developmental trauma, you know, it kind of shows up differently in different ages and stages, the same things. Or we may have a certain level of healing with one area and not another, or we sense the comfort of the person we're speaking with who may have something to share or guide us or feels familiar and safe for us. And that may change what we're willing to share as well. So yeah, I guess that's what I have so far.
Thank you so much, Sissy. One question that I have, and maybe you can say a little bit more about some other personal examples of helpful encounters versus kind of harmful ones, but just in terms of sharing your story at various points, to do with because you kind of described there the discomfort on the part of some people when you chose to disclose certain things or felt they were relevant in a given setting. So their nervous system was sending you extremely clear signals that, you know, please don't tell me I'm not able for this, or betraying whatever kind of, I suppose, activated emotions, or I don't know, repulsion at times, or fear, anxiety around what you might disclose. Were there then times where someone's nervous system was very different in when you were sharing? For example, I think you've written about when you heard about the ACE study first with a healthcare provider or alternative health provider, and how that was quite a healing encounter.
Oh yeah, I mean, there are some people that, you know, I went to a functional medicine practitioner when I was in my 40s, and I think one of her first questions was, were you a wanted child? And I was like, what? How does that have to do with anything? And that was a way of getting at my family history. And I was like, you know, I was the second child and my mother was 18. I was like, I definitely wasn't planned. You know, I mean, she kept me, but I wasn't a planned child. And we started from there, but it also gave me a sense that she was asking us to everybody. It wasn't specifically like she wasn't trying to get underneath like, what is your label or what is your diagnostic DSM, kind of like what are your problems, what are your behavior issues, like what are your troubles. It's just giving a general sense of childhood shapes all of us. So I ask all my patients, were you a wanted child? I ask all my patients, did anything difficult happen in the first 7 years? I ask, And then she would ask from 7 to 14, like this is a key period, and would ask about major life issues. And then from 14 to 21. And that was her way of addressing, but it made it so comfortable because she did it with everyone. So she was very comfortable with this routine. It opened up something very different than when someone says, what does your father do? And I say, I don't know. I don't know my father. In which case some people can shut down. What do you mean? And then if I say he's homeless, then people can really struggle with like an appropriate response. So then I end up saying like, it's fine. I talk about that in therapy. Like, it's like, we don't have to deal with that here. But when I was younger, I would just feel shame. Now I can say something like, it's uncomfortable, or, how many of people in our community, are like, I worked at a shelter for homeless families. And there was a very specific idea of who's homeless. So then when you're talking to somebody in a different setting, when that's not necessarily a population they know about or something, like it can be jarring for the other person, and you can feel that, and then you shut down as the survivor, like it's not safe to talk about it, or I'm making them uncomfortable, or I'm making them feel bad, or there's something about my story that's not normal, or not. You end up taking it on, like the shame of whatever the culture has. It can kind of get amplified in a single setting and just maybe make you feel worse, because the tyranny of silence, as you were saying, Jane, there are certain conversations none of us have been taught how to have. So there's not like so my personal view is, if we were, and why I like to talk about ACEs is, I think if we're more comfortable understanding how many people have adversity, which we know from if you read a book and you watch movies, if you're a writer, like we know there's all these dramas and human dramas, but in some settings we pretend they're not appropriate, or they don't actually happen, or it's not the place to, acknowledge or discuss them, which does send people a message. And I think silence is not benign. So I think I personally like, opening the can of worms too, because not talking about it, some people think just not talking about it is like the safe way to go. If I don't know how to talk about it, it's more safe to avoid the topic. But that sends a very clear message to many people, like you have an unspeakable experience, or you have an experience that I'm not even comfortable with you speaking. And that says volumes. Like that is not, that is very felt to the person. The silence is felt very loudly. So I think opening the can of worms and just opening it for everybody, I guess that's the thing, is you making it more universal, like just we don't have to have shared the same experiences to understand that the presence or absence of trauma and resources is impactful. We don't have, I think in some ways talking about ACEs and trauma for many people is like talking about racism. Like it's just super uncomfortable, and some people would prefer to not talk about it at all. And we think talking about it poorly and clumsily and awkwardly might be worse than not talking about it at all. But that only benefits the people that already benefit from silence and that already have privilege. So that silence is really for the comfort of the person who's already got a privilege and is already usually in a position of power. It's not like survivors have clamored for silence. Most of us are pretty big on breaking the silence, or sharing our truths, or finding safe ways to just be able to own our experiences the way that other people do, and just to feel as comfortable doing that as other people do. I think sometimes we forget that that's all really survivors are looking for, is just to be at the same like humanity table, being able to participate in conversations. I think a lot of survivors spend an inordinate amount of time suppressing and dodging around topics that feel uncomfortable, either for us or because we know they're uncomfortable to who we're speaking to. And that's unfortunate, because the bonding, it keeps us from bonding, it keeps us from connecting, it keeps us from being able to be honest with one another and disclose, including in settings where we're seeking treatment and we're going for help. And I guess some of the examples of like good and bad examples, like I worked at a shelter for homeless families, and my father was homeless at the time. And I think I've told you this before, Jane, but the very first day I worked at this, it was a residential shelter. So families were there for 6 months, which in the US is a long time to be at a shelter for homeless families. Usually it's less. And the very first day, I was a college student. I was the first person in my family ever to go to college. But the very first day I was volunteering at this shelter, I was asked to help the mothers to model parenting interactions. It was assumed that as a college student without children, I would know how to parent and model to show homeless families who didn't necessarily have any flaws in parenting. They were without homes, but it was assumed that they would need parenting skills. And I was like, what does that have to do with being homeless? Like, I thought the solution to homelessness is housing. Like, but it was a lot about manners, going to bed on time. There were curfews. There were a lot of very rigid rules about behavior, not sitting down on the ground when you were eating, like things that it really implied that there was something fundamentally wrong with people that made them homeless, and that was going to be addressed while they were at the shelter. They weren't just being sheltered. So those kind of messages. And so I ended up interviewing, because I ended up getting a job as a relief staff. So I'd work a 24-hour shift, and I ended up interviewing the staff, and I interviewed the residents. So what did the staff see their job as, and what did the residents see this role of the staff as? And it was very different. It was not the same at all. So I think even just understanding like the roles we see ourselves in versus the roles the people that see us. If I work in an office and I have the keys to the food, and every time somebody wants to make dinner, they have to ask me to open their fridge because I don't trust that you won't take 6 burgers instead of 2 burgers. Like that's a power differential. Even just every time I'm getting food, I need a key. Every time I need the bathroom or I need shampoo, I have to get permission. Like we're saying something. So things like that. But there have also been experiences that are super positive where some people will share that they understand PTSD. Like recently, I'm dealing with ovarian cancer right now, and I'm currently on chemotherapy. And my current oncologist has done a study and found out that 1 in 3 people who have ovarian cancer will develop post-traumatic stress. So that's even if you hadn't had a prior history. But when I first met him, I was able to say, I have PTSD. So for me, agency is, I am more afraid of losing control than I am of losing my life. That's not true for everybody, but for decisions, for medical decisions, for me, I need a lot of input. I need to understand it. I need a lot of explanation. And I could say like, that's really important to me and will make me much more likely to go to appointments and show up for appointments. But if I don't understand why we're doing something, there's a chance I just might not show up. So if you give me the explanation on the front end, it might take a little bit longer, but I'll be very compliant because I understand it. If I don't understand it, I'm not likely to be compliant. But at this age, I'm able to say that. In my 20s, I wouldn't have been able to say that. I just would have not come back to an appointment if somebody didn't explain why they wanted me to do something or why they were doing something. I would have just run. So I think also understanding people at different ages and stages, what people need, and how much people are able to advocate, how much we're able to advocate for ourselves also changes in the course of our lifetime. And it also varies depending on our experiences, not just personally, but historically with systems. Like if I'm in a school system, at least in the US, school systems are the #1 reporters to Child Protective Services for Black families, but not white families. So a school system is a different place in terms of if you're having troubles and struggling with parenting, how safe it is to talk to the school teacher or the school nurse isn't the same universally. In the United States, it's police officers and police and the criminal justice system that's most likely to report Latinx families to Child Protective Services. For white families, it's anonymous that's most likely to report white families to Child Protective Services. It's not a specific system. And most people don't use their name if they report a white family. So that would vary and impact relationships with systems for the whole family, depending on what experiences my mother had or my aunt had or my sister had. So again, I think sometimes the cultural competence that's discussed at the end, I think sometimes should be the first thing, because it's gonna impact how we even show up at the first appointment, and how, whether or not, like I talked to Jim's board leader about this too. I'm like, you know, as a white person, I might feel like school is a safe place. For me, it absolutely was, but that is not a universal experience when we have in the US now a lot more police officers or school safety officers showing up at school. It's not equally impactful on all families. For some people, that's a trigger and a threat. For other people, that brings a sense of safety and makes people feel more safe. So the same person showing up in a school system can have a different impact on different communities and different people. So I think that's the complicated part, is that it is everything is contextual, relational and contextual. So I think kind of that's the good news and the bad news. I think it's both. Yeah.
Can I ask you one more, and then I'll throw it out to the others, if the class, if they have any questions for you. But one of my favorite pieces that you wrote was about kind of a letter to your younger self, or what you would have loved to have had access to, a person who was older than you, who had lived through similar experiences, but who was having a life, you know, who was able to be healthy, comparatively happy, safe, enjoying a sex life, able to sustain a job, you know, all that kind of thing, when you were in your mid-20s, around the time you got your PTSD diagnosis. Can you tell us a little bit about that piece of writing, Sissy?
Absolutely. And in fact, I wrote that piece of writing when I decided to start. I had been a writer my whole life. I'd been a reporter, but when I wrote about I kind of dodge and weave around my personal experiences. And I realized in my 40s that the thing I was craving the most, and had always craved, just knowing someone had been through something similar, or preferably worse, like that was, you know, someone had been through something similar or worse and had come out better. That was in my thinking in my 20s. I wanted to see examples of someone that had been through something hard, because I didn't always believe providers. I had one provider who said, you'll never have a sex life. You'll never have a normal sex life. A therapist, because of what was done to you. And that felt prescriptive, you know, like it was terrifying to me. And for a long time, I believed that. And because I already feared that that was true. So I wanted to meet people that did go on, that did have a lot of trauma. And in my case, that same trauma, and then had found not just a way to like not be in agony, but to maybe be at peace, to have a healthy life. And wasn't necessarily a clinical voice I was looking for. I was really looking for somebody attainable in real life that like maybe carpooled and also went to the grocery store and didn't just show up in clinical texts, like just a regular person that had a complicated life. I wanted to believe that that was possible, and also that somebody could be so shame-free that they were willing to talk about it without shame. And that was really, really hard to find, except in fiction. I mean, almost impossible. And in my 40s, I realized I've craved this my whole life, and I'm not willing to publicly speak about my own trauma and being a survivor, even though this is stuff I write about, it's a subject area of interest. that's when I decided, like, I am not even being the thing I'm craving to other people who are younger. So that is what gave me the courage to be more open and just be like, I don't have to be ashamed of this. This is actually, it does impact my parenting. It does impact how I show up in my relationships. It does impact me. But I also have a life, and I don't have to wait till I'm 100% healed to be able to speak about my life any more than anyone else does. But that took until my 40s. That's what I felt was missing, because if we only keep this survivor identity as clinical, it's still centered around something broken and flawed that you're fixing or healing, as opposed to there's also wisdom, there's also growth, there's also just, it's just a part of a human experience as well. Not to minimize the trauma, but to normalize it a little bit, that for some people it's just the way we started out, but then we can recover and heal and make sense of our lives and have a decent life and still be able to acknowledge our history, our past without shame, and remember that, again, the ACEs are things that were done to us or not done to us, that were done for or not done for us. Like, they really don't say much about me at all. And I think that the way that in the past trauma has been, it's so shameful. You think it says everything about your entire being, because you don't hear people speaking about it conversationally or casually, or speaking, like when I talk to other survivors, we hardly ever share what happened, the specific details. What we're talking about is, when we're activated, what do we do? Like, if we're in the middle of parenting and something comes up, we're sharing parenting tips, we're sharing partner and relationship stuff, just like everybody else. Like, it's really more about the present. How does the past impact our present? And then what do we do about it? Those are conversations many of us are having with one another and seek. And until really social media, when we could get access to one another somewhat anonymously and then decide if we wanted to be more open, we might do that at in college or in a women's circle. We might do that in a therapy setting. It was very rare that there were places where we were able to just acknowledge our history, share about it shamelessly, and acknowledge a wider context to our lives as well. And I think there's a lot of power in just being able to do that. And that's why I think the ACEs, for all its problems, which it has many in terms of how it could potentially be weaponized, it does give a language that's a little less shaming and more neutral, that just helps all of us, I think, understand how common adversity is in childhood and adulthood for that matter, but especially in childhood, how it impacts us if we experience a lot of it while we're developing.
Yeah, thanks, Ceci. I'd agree with you that I think for an awful lot of people, the ACEs framework appears to be quite liberating and a bit of a light bulb moment for many, not all, but for many, and kind of explains that some of the enduring problems that people might have are actually quite normal and predictable given the accumulation of such stressors.
Thank you so much.
So that was Ceci White, who spoke live at a session previously, and she's a wonderful writer. You can check out her blog, Heal Right Now. She used to work with ACEs Connections that became PACEs Connections, and I interviewed her as well for my How to Talk Policy and Influence People series. But she described pretty well how services and helping professionals can reject and harm survivors by, you know, heaping further shame and blame on them for the coping strategies that they adopted in childhood or whenever the traumas occurred, that really were initially adaptive behaviors to cope with the overwhelming stress. Richardson and colleagues have an interesting quote here from a 2012 article saying that awareness and acknowledgement that maltreated children have experienced significant trauma is increasing throughout the children's services world. And if asked, there would be few children's services professionals who would deny that most children entering foster care have experienced trauma. It is the understanding of the impact of traumatic experiences that has been lacking. This is harder for professionals and caregivers to accept, as it runs contrary to the medical model, as well as traditional child rearing practices. Even when these models are ineffective in dealing with these children, the idea of achieving and maintaining equilibrium, as systems theory reminds us, is a powerful force. In practice, this means that change is hard and takes conscious, considerable effort to institutionalize. It explains why, even when a practice and a paradigm of understanding these children is ineffective and even harmful, people and systems continue the same actions as always. It is a long process to allow a paradigm shift to take hold. So we're going to talk a little bit now about Sandy Bloom's sanctuary model, which I mentioned in a previous session. It began in Philadelphia in an alternative psychiatric setting, and her colleague Joe Foderaro is the person who originally came up with the wording, "It's not what's wrong with you, but what happened to you." And so Sandy Bloom used a powerful So Sandy Bloom uses a powerful theater metaphor in her book, Creating Sanctuary, to explain the importance of refusal by authority figures and the wider social group, so other patients in the psychiatric facility, for example, including support staff as well, cleaners, and everyone in the building has a role to play to respond on cue to a person's trauma scenario. I'm going to start again. So Dr. Sandy Bloom created the world-renowned sanctuary model, and she uses a powerful theater metaphor in her book, Creating Sanctuary, to explain the importance of authority figures and the wider social group in refusing to respond on cue to a person's trauma scenario. The thing about traumatic reenactment is that it's like a traditional piece of theater where the cast perform the same lines the same way night after night, with no deviation from the script, no changes to the movements on stage, and the same exact ending. Improvisation, by contrast, is a lot more vital and organic. There is no fixed predetermined ending or desired outcome. Improv requires performers to think on their feet and to be open to possibilities, receptive to giving and receiving with spontaneity. This is exactly what trauma survivors need to learn: new ways of acting and interacting with people for better, healthier outcomes. I think that's actually from how I put it in my own PhD, but the pages, if you can get hold of Creating Sanctuary, are page 263 and 264. Bloom says that the rehearsal of new ways of thinking, feeling, acting, and interacting could only occur within a rich social context in which connecting to other people was given high priority. So raising awareness of trauma and adversity and what it can do to the autonomic nervous system, fight, flight, freeze, fawn responses, ability to relate, traumatic reenactment, all of this is very important for absolutely everyone working with trauma survivors. And trauma survivors also need this information, so that if I'm in the psychiatric facility with other people, I can spot when someone is trying to elicit a rejecting response or provoke me into a confrontation, and I can try and resist. And it's little by little, if we don't explode when someone becomes explosive, if we just say, you know what, I can't deal with this now, I'm going to have 10 deep breaths, or I'm going to leave the room, I'm not going to fight fire with fire. These little changes can slowly help people to expand their window of tolerance and realize that it doesn't always have to be this way. We don't always have to become aggressive towards others when we're frightened. We don't always have to self-harm or dissociate in order to deal with unpleasant, frightening emotions. There are other things that we can do, and relational rupture, as Karen Traceman says, requires relational repair. We all have a role to play in this, absolutely all of us. These are a few pictures from Moana, and in the next couple of slides, I refer to a really interesting article by Jade Hawthorne and Dr. Adam Burley about Moana. And what's really interesting is Jade is someone that Adam has worked with for quite some time. I've also done an interview with Adam for my Relationships Matter podcast. But Jade has an extensive complex trauma history, developmental trauma. She's been accessing homeless services, I believe. And she's not someone who would find it easy to trust other people or to believe that they want to care for her or that she has value in life. And if we develop an internal working model as small children that says, I am bad, I am worthless, no one could like me, let alone love me, then that's what we carry forward into the world, including if we need to access services at any point. We will mistrust anyone who makes an effort to care for us. Anyone working with trauma survivors needs to know this and not take it personally if our efforts to be caring are rejected, or if they elicit a negative response, if people run away from us. It is because being cared for feels so strange and actually threatening. The rejection and abuse of the past has a safety around it because it's what feels familiar. But you can read the Leaving Lockdown, Moana, Trauma, Voyages of Discovery from Clinical Psychology Forum. It was written or published in October 2020, and I'll share the link afterwards. But it's Jade and Adam go through the story of Moana, and Adam is the one who writes the article, but built on the reflections that Jade and he discussed in various sessions. And he says, deep ambivalence about change towards relationships that have been previously brought pain and suffering feels like a story that I have heard many times while working with those who have experienced childhood adversity. That is the norm. Trusting and feeling safe with other people is not the norm. Dr. Bruce Perry has a phrase for the sequence of engagement. This is the optimal sequence of engagement for traumatized people, but not just traumatized people. Really, it works this way for anyone who's any bit distressed, or if we're trying actually even to just get people who we don't know to want to collaborate with us. We should focus on regulation, relation, and then rationality. So regulate, relate, reason as the sequence. Because if someone is dysregulated, so let's say we're trying to bring together a multi-agency partnership, for example, and there's a lot of hostility between services like the police and social work, perhaps psychology, they don't necessarily work well together, or they might have certain preconceptions about the others. So they go into the room a bit dysregulated, a bit kind of suspicious, what is going to be asked of us. So if we can focus on regulation to begin with, and a real emphasis just on listening will help with this. And so things like restorative circles are good ways of establishing our common humanity, because they're egalitarian, and you can lay down certain values that mean that we're more primed to listen to one another and actually spot the fact that for whatever differences we might have as professionals, or even whatever ethnic differences might exist within the group, essentially we all need and want the same things to feel well. And if we get the regulation right, if we listen to one another, listening is an opportunity to co-regulate with one another, and it regulates neural state. So then we're open to relating better to one another. If we relate well to one another and sense the energy, the positive energy flowing between one another, then we're going to be in our cortex, and we're going to be receptive to new learning and new ways of thinking, and maybe can collaboratively spot new directions for positive collaboration. But with trauma survivors, this sequence of engagement is even more important, because people spend an awful lot of their life dysregulated, which negatively impacts their ability to relate and completely derails their capacity to reason. It's not that trauma survivors cannot reason. It just means that they very often are not in that headspace. They are not in their cortex. And so they're not very well able to inhibit their impulses. They're not able to plan for the future. Their language capacity can be diminished because they're more tuned into low-grade predator sounds than the human voice, for example. But physical, psychological, social, and moral safety, which were the bedrock of Dr. Sandy Bloom's approach to working with trauma survivors, are very important. The same principles should apply in creating any enabling environment, whether it's a classroom, a domestic violence service, a prison, or an addiction setting. You can watch Bruce Perry's 3 R's video about regulate, relate, reason there at the link, and you can also watch State Dependent Functioning again if you haven't watched it already. Dr. Richard Swartz has an interesting model of engaging with trauma survivors called internal family systems. Essentially, it's a lot of parts work, because people with complex trauma histories often have a kind of splintered sense of identity, where parts of themselves might be repressed, or parts of themselves might be firefighters, you know, they might be obsessive or compulsive or violent or dissociated or suicidal or engage in binge eating and addictions. Or they have parts that are managers, that are controlling, that are striving, that are self-critical, or always trying to take care of other people. The exiled part of themselves might be exiled rage. So they have a lot of rage, but they park it as far away out of conscious feeling as possible. Or shame. They might have a lot of exiled shame or grief. And these really need to be confronted and engaged with empathetically, with curiosity and compassion, in order to move forward and have a healthier future. So it's an interesting way of working with the various parts that can be present but not acknowledged by people with trauma histories. This other image of the green heads with the kind of thorny looking neurons is to just, again, remind us of interpersonal neurobiology by Dan Siegel. Our brains develop and change in the context of experience and relationships. So that is to do with the concept of neuroplasticity. Even if we've had very tough times in our early childhood or in our teens, we can get our neurons to fire and wire together differently if we learn how to connect and to form healthy, boundaried, reciprocal relationships. If you work with trauma survivors, it really is all about the relationship. You can deliver whatever modalities that you like, but they won't really work if the engagement with the person isn't connected, really. Ideally, the person should feel that you care about them and want them to be healthy and to do well. And according to Bessel van der Kolk, the therapeutic relationship is the most important thing, but especially if you can help a person with their emotional regulation. Again, babies and small children do not learn how to regulate their emotions on their own. First, there needs to be co-regulation, ideally with their caregivers. If co-regulation occurs, then they will learn to self-regulate. But without co-regulation, there will be no self-regulation. So this is the therapeutic engagement is a way of helping people to learn how to regulate their own emotions. But to do that, they need to feel safe and they need to trust the person, and they probably do need to feel cared for. But sometimes, as Jade and Adam Burley point out, feeling cared for in and of itself can be quite frightening. Mary Glasgow from Children First in Scotland spoke at the ACE Aware Nation event in 2018 and said, relationships are an evidence-based program. So if you work with trauma survivors, do strive to be an empathetic witness. I've mentioned before probably that my favorite definition of trauma is that trauma is not what happens to us, but what we hold inside in the absence of an empathetic witness. Gabor Mate wrote that in the foreword to Peter Levine's book, In an Unspoken Voice, How the Body Releases Trauma and Restores Goodness. It's a great book. According to Peter Levine, who created somatic experiencing, therapists or people in caring roles should shut up, be present, show up, be present, and shut up. So don't always be, focusing on yourself. Focus on the presence, the being there, the presence, and the connecting to the other person, and let them really do the talking. Try to help people feel safe with you so that they can feed their good wolf. That's a reference to the Wolf of Hope and Despair story. Safety starts with people's bodily sensations. Be patient, be kind, believe people when they reveal trauma, and do watch your own trauma triggers. Unlike highly traumatized people who haven't properly digested what they've experienced, you may have choices about how you respond to the behavior of others. If you have a trauma history yourself, you're more likely to have a smaller window of tolerance maybe, or certain cues. Certain triggers are going to be problematic for you. So again, self-reflection is very important, as is self-care and compassion. Here are some signs of vicarious trauma, secondary traumatic stress, and compassion fatigue. The link at the bottom of the page there of the slide is where these come from. So physical signs include insomnia, headache, sore back and neck, rashes, breakouts, teeth grinding at night, heart palpitations, hypochondria. Behavioral signs are things like increased use of alcohol and drugs, anger and irritability at home and at work, avoiding colleagues and staff gatherings, impaired ability to make decisions, imposter syndrome, feeling unskilled in your job, problems in personal relationships, difficulty with sex and intimacy due to trauma exposure at work, thinking about quitting your job, which isn't always a bad idea. Emotional and psychological signs include emotional exhaustion, negative self-image, depression, impaired appetite or binge eating, feelings of hopelessness, guilt, dread of working with certain clients, diminished sense of enjoyment of the career, depersonalization, so spacing out during work or the drive home, distorted worldview, heightened anxiety or irrational fears, hypersensitivity to emotionally charged stimuli, insensitivity to emotional material or numbing, and then suicidal thoughts. Dr. Sharon Lambert did a talk about vicarious trauma in the Towards a Trauma Responsive Criminal Justice System, Why, How, and What Next, which I suggested to the then Director General of the Prison Service, and had a role in organizing this trauma conference. But Sharon wrote that trauma contagion refers to the concept that working with trauma survivors may increase the risk for vicarious trauma, secondary traumatic stress, and burnout for some. The terms are at times used interchangeably. According to Perlman and McKeon, vicarious trauma occurs following long-term exposure to the stories of traumatized service users and may cause decreased motivation and empathy. An additional feature of this is a risk of a distorted worldview. The experiences of workers in frontline services represent a small minority of the general population as a whole. However, if a worker develops vicarious trauma, they may perceive their world as more unsafe than the actual statistical risk. staff may isolate themselves from others who do not work in frontline services, as they no longer hold similar views of risk, danger, and trauma, and may tend to gravitate more towards others who share similar occupational experiences. Secondary trauma stress differs to vicarious trauma in that it does not change a person's worldview. It has instead been described as a syndrome among staff working with trauma survivors that mimics post-traumatic stress disorder. Burnout then occurs when the demands outweigh the resources and results in physical and emotional fatigue that may also result in disengagement from work and the depersonalization of service users. So Sharon Lambert also did some work with Reagan Murphy, her colleague at UCC's Applied Psychology Department, where they explored frontline service professionals' levels of trauma and the link to burnout and secondary traumatic stress. People who scored higher levels of burnout were almost twice as likely to have higher ACE scores, so 4 or more, than those with lower ACE scores. And this is really interesting because it might mean that people with high levels of adversity are likely to find themselves in certain professions because they want to make a positive difference, but then they're more likely maybe to be negatively impacted by the trauma histories and narratives of other people, and might be burned out or numbed or emotionally reactive. It's very important that people working with trauma survivors learn how to manage their own stress and to mind themselves. So some polyvagal informed activities that regulate the nervous system include listening. As we've said before, this helps regulate neural state through co-regulation. Humming, my son loves humming and finds it very soothing. Singing, especially in a group, because there's something about being in a group, the energy of the singing and the joy of the music, that's really positive. Deep belly breathing, like coherent breathing, yoga, dance, movement medicine, which is a practice that I do myself and really, really enjoy. Drumming. Drumming is really excellent for left and right brain integration, and trauma releasing exercises as well are very positive for getting the body to tremor and to release some of the stuck frozen energy and stress. There's a link there to a free online TRE class that was developed for lockdown to help people to deal with the increases in stress and tension and anxiety. Theatre, art, journaling, massage, acupuncture, walking in nature, gardening, nurturing contact with animals are also really beneficial. And that's that. We've reached the end. Our final class next week is on the role of the community in preventing and healing trauma. Thanks for your attention. I hope you found it useful, and I particularly hope that you found Cissy White's powerful reflections as a trauma survivor useful, and bear them in mind if you work with trauma survivors going forward. Thanks. Bye now.